Well, thank you, Dr. Krieger. I just want to convey how thankful I am to be here for ABC, for providing the platform, and the surgeons and physicians for your mentorship over the past few years, but most importantly, the patients and the families. So we've been sharing our stories, and my extrophy journey started a dozen years ago when I was a medical student at University of Michigan, go Blue. And one of the first surgeries that I was able to be a part of was a bladder exstrophy closure by Dr. John Park, who is a dear mentor of mine. And at that moment, as soon as the surgery was done, I knew that this is what I wanted to do. And I was telling Kelly, a mother of a patient with cloacal exstrophy, that at that time, I think I went in it with the wrong idea. I was mesmerized by the surgery itself, but over the past dozen years, I've kind of learned about the patients. I've learned about the parents. I learned about the strength, perseverance of the families and patients with bladder exstrophy, epispadias, cloacal exstrophy. And it really inspired me to be a better father, to be a better husband, to be a better physician. And it's really what drives me, what gives me purpose in life, to wake up every morning knowing that I'm striving to do something better. I'm serving my life's mission and trying to do some good in the world. And I want to thank you. You have no idea how much you mean to us physicians, as well as other friends and family members. So with that, I don't think bladder exstrophy or cloacal exstrophy, epispadias, this does not define your family. It does not define your child. I made a huge mistake, one of the biggest mistakes that I can remember that I felt very bad about. I was giving a presentation about Down syndrome, and I kept on saying Down syndrome boy, Down syndrome girl. And one of my colleagues ran out of the room at that time crying. And I talked to her afterwards, and she had a son with Down syndrome. And the way I was kind of speaking about it, I think it made her feel kind of it was not personal. This disease does not define your child. And I just want to emphasize that your child can do anything he or she wants, puts his or her mind to. And I think that's very important. I'll be talking about some of the diagnoses that a cloacal exstrophy patient might have that's different from epispadias or bladder exstrophy. And that disease process does not define your child. So I like to think of it like a zipper. To the right would be cloacal exstrophy. It's the biggest opening. And then the middle would be bladder exstrophy, medium opening, and epispadias, just the tip. And it's a complex, it's a spectrum. It's exstrophy, epispadias, complex, and I like to think of the complex representing C for cloacal exstrophy. And then epispadias is a least or the lesser degree of the spectrum, where it's most zipped. The urethra is on the outside, but the bladder and the bowel is on the inside, and it's not as common. The next would be the medium zipped bladder exstrophy. Urethra is on the outside, bladder is on the outside, but the intestine's still on the inside. It's the most common diagnosis. That's probably why we don't have a cloacal exstrophy support group in of itself, but the numbers would be too small. And then the next would be cloacal exstrophy, also known as OEIS syndrome, O for omphalocele, E for exstrophy, I for imperforate anus, and S for spinal defects. I'll be going into that more in detail. You probably have seen some friends in this group, or ABC, where they're in wheelchairs, and you're kind of wondering, oh, like most people with bladder exstrophy aren't, their lower extremities aren't affected, and you're probably seeing a patient that may be affected by cloacal exstrophy. And it is the least common, but most severe. Today I want to take this opportunity to kind of talk about the major differences between bladder exstrophy and cloacal exstrophy, and most of the time I'm going to be grouping bladder exstrophy and epispadias together. So pre-birth, let's start. Maybe we're going down some memory lane. Before birth, if you have a child with bladder exstrophy or epispadias, you're not really making changes to the prenatal plan or the delivery plan. And the exstrophy, we studied this across our 3 groups. The prenatal diagnosis rate in the United States is about 60–70%. It has increased significantly over the last 20 years, but it's still not perfect. For epispadias, typically it's a lot lower. It's not reported in isolation, but it is typically not diagnosed at birth. And this is a little different from cloacal exstrophy. As I mentioned, it's a syndrome, and it's a cascade of events that impacts the spine, which can be clearly seen on prenatal images. So the diagnosis rate is quite high. It's greater than 80–90%. And typically, if this is detected in the prenatal period, you're having discussions with maternal fetal medicine about where to deliver, especially because delivery tends to happen earlier. There's a lot of preterm births in cloacal exstrophy, and after births, it's imperative that you get intensive care to prevent infections, to prevent malnutrition, to make sure that the bowel is diverted okay, to make sure that the poop doesn't mix with the urine. And then right after birth, for bladder exstrophy and epispadias, it was striking where our winner was talking about after birth people were transferring her emergently to the nearest intensive care unit, and you might have experienced that in your own past. But we have to tell everyone, okay, it's the bladders and the outside, but the heart and lung and the brain and the spine, that's all normal, so there's no emergency here. And typically we recommend that we put a soft tie in the base of the umbilical cord, we cover up the bladder plate, and you seek somebody like Dr. Krieger as soon as possible. And then for cloacal exstrophy, the story is quite different. You do need to be in the intensive care unit, in the neonatal intensive care unit, and you need to seek counseling from a general surgeon, a urologist, a neurosurgeon, as well as a nutritionist, as well as a nephrologist, because it used to be that the mortality rate was very, very, very high in cloacal exstrophy, specifically for infection reasons and kidney reasons, that till to now in a tertiary center, you have a survival rate greater than 90%. So let's move on to kidney health. For bladder exstrophy and epispadias, the kidneys are typically normal at birth. But as Dr. Groth said, there is a cost to continence. And the question becomes, are you willing to take those risks to be dry? And I think it's very important, I can't emphasize how important it is, that you've had surgeries to get dry, that you continue to get your kidneys and your bladders monitored so that you don't have a system that's blocked, and that you're not, if you have an infection or recurrent infections, that you find a way to minimize them or improve upon them, because you can have long-term renal effects even if your baseline kidney function was normal. In cloacal exstrophy, it's a little bit of a different story. In cloacal exstrophy, 70% of patients have some type of renal anomaly. The kidneys can be located in an abnormal location. 2 kidneys can be at the same side. You can have one kidney or both kidneys are low in the abdomen, kidneys that are born blocked, kidneys that are born where urine is going up the wrong direction. So at birth, the kidney function is not normal. And then turning into spine, I said OEIS, the last letter S stands for spine. And we talked about the epidural before. We can place an epidural in epispadias and bladder exstrophy patients because the spine is normal. That has a lot of impact, significant consequences on continence. And Dr. Weiss talked about continence, how it's important that there's a distinguishment between continence and being dry. And we strive for continence in bladder exstrophy because the nerves to the bladder through the spine are normal, we like to think, and that also has significant impact in cloacal exstrophy because we think that in cloacal exstrophy, the nerves to the bladder and the lower extremities are not normal. So cloacal exstrophies that undergo surgery typically are not candidates for something like an epidural. There is a huge spectrum within cloacal exstrophy in terms of what kind of spinal defect that one might have. 35% of cloacal exstrophy patients are able to ambulate. Another third can ambulate with assistance. The next third cannot ambulate or are wheelchair bound. So there is a huge spectrum of differences in cloacal exstrophy, and there's a lot of overlap between myelomeningocele or spina bifida, and that's a huge portion of patients that we take care of, and cloacal exstrophy, and the common theme between those two diagnoses is the spinal abnormality. And just going back, talking about cloacal exstrophy, typically, and this is not the rule, but typically for cloacal exstrophy, we strive for patients to be dry when they are ready and when they are ready to take the risk or the cost of continence. And we're not expecting cloacal exstrophy patients to achieve continence because a coordination between the bladder and the sphincter are typically not normal. So then, I think this may be the most important difference is the gastrointestinal health. For bladder exstrophy and epispadias, the anus can be a little anteriorly located. So before closure, a lot of the pressure when the babies are crying, that pressure is going straight to the rectum. So sometimes you see a little bit of prolapse in the rectum, but after we close the bladder, that pressure is actually going to the bladder and you don't see as much of the prolapse anymore. And when the bladder is closed, the rectum doesn't look as much anteriorly displaced. And that's really, and then I think because of the pelvic floor abnormalities that Dr. Weiss was talking about, there is some issues with constipation. I have 3 kids. Their poops are all really hard and really big. So I think it's something to do with PASA and the way we feed our kids. But in cloacal exstrophy, this is a huge and probably the most important aspect. Sometimes it could be the limiting aspect of their care is that at birth, you're born with a segment of intestine that is oftentimes very short. There's 2 segments, the short segment and the long segment, and often the long segment does minimal work, and part of the long segment is kind of not really there, and the long segment splits 2 bladder halves in the middle. And that ultimately leads to lifelong issues with absorption of fluid and nutrients, and oftentimes a lot of diarrhea that prevents the kids to grow normally. And this has a huge impact on how we manage these patients, what kind of surgeries we offer these patients, and long term, if they're dependent on the IV, it has a huge impact on their life expectancy and their quality of life because oftentimes they're in and out of the hospital due to repeat infections. And then we were talking about musculoskeletal health. We were talking about the pubic symphysis not meeting in the midline. When you feel underneath your belly button, we feel a bone. Those of us who don't have bladder exstrophy, kids with bladder exstrophy don't really feel that bone. And that has a huge, I think, correlation with penile anatomy as well. And this is a huge pillar of our surgery where the orthopedic surgeons help us make incisions so that we can safely close the bladder. And even though our bones are a little externally rotated, the kids with epispadias and bladder exstrophy are very, very accomplished athletes in my experience with them. A lot of great goalies, a lot of good horseback riders. For cloacal exstrophy, the pubic bones are often very far apart. I'm talking about like 10 centimeters far apart. And we might not just get away with osteotomies. We may need to do additional, more complex orthopedic work. And as I mentioned, there's a wide spectrum of ability to ambulate in patients with cloacal exstrophy. And then bladder health, I think this is probably what a lot of us are thinking about in our room, because this is something we experience every day. Bladder training or voiding is such an integral part of our social experience that I think this is very important. It's the ultimate goal, right? To have a patient with bladder exstrophy who can void on command. For cloacal exstrophy, as I mentioned, it's not really, I think in my mind, I stand to be corrected, but it's not about continence, but it's about being dry and then understanding the risks and the surgeries that it will take to get dry. And whether you want to take those risks. And if you do, when do you want to take them? Are you going to be able to send the kid to school with providers that you feel comfortable with, that understand the risks of not being catheterized normally? Are you okay with providers who are going to take care of your kid, who are going to be okay with your kid being wet, and who are going to change the pads so that there can be some prevention of rashes in the perineum, etc. Well, those are all things that you should think about and ask questions for when you're speaking to your providers. And the reproductive health, we mentioned this briefly, but for bladder exstrophy and epispadias, for biologic males with bladder exstrophy and epispadias, typically the testicles are going to function normally, healthy swimmers, I like to say. And then for biologic females, typically there's one uterus, one cervix that's working, and then one vagina. And there may or may not be some issues with the vaginal orifice being a little narrower than we would want, because of this initial surgery does involve some manipulation of the vaginal orifice. But these are things that are typically the issues for a patient who's female with bladder exstrophy. For cloacal exstrophy, for biological males, there is an issue where the testicle is sometimes up in the groin or in the belly, but typically, once we bring it down normally, if the patient does have like chromosomes of XY, the testicles are typically producing some healthy swimmers that are going to be competing in the Olympics. But for biological females, it's a much more complicated story. And I think this is something that we need to write more and think more about in the literature, is when we can should be identifying structures of the Mullerian organs, Mullerian meaning the reproductive organs for the females, because they can be quite prominent in the newborn period, but they go dormant. They go into hibernation for a long time until before puberty. And we've had a handful of patients that we've taken care of in Boston where they come in with recurrent abdominal pain, then they get a catheterized specimen, the urine culture is positive, everyone's saying the patient's getting recurrent UTIs, and lo and behold, you get an X-ray or a CT scan, and there's a giant uterus, there's a giant fallopian tube, there's a giant blocked vagina. There's oftentimes, more often than not, there's two of them. And sometimes it's just right near where the perineal surface is. And you need to work with a general surgeon or a gynecologist or somebody and a urologist, somebody who understands anatomy, to make sure that those structures are not being obstructed. And this is very, very nuanced. And this is something that you might not be thinking about or wanting to think about. But there is a complexity of the vaginal location, how wide it is, how deep it is, whether your child may be ready for vaginal dilations. That's something that you might not have had the opportunity to think about, but it's something that is very, very important, I think, and the timing has to be right. And then sexual health. I think that parents, if you're not talking to your kids about sex, and who are teenagers or preteens, they're probably thinking about it. And for kids, if you're thinking about it, I think you should talk about it. We have a support group twice a year at Boston, and this is something that was discussed at length during the last support group. And I asked the whole group, hey parents, and older teens, young adults, what do you think? When's the right time to talk about this? Who is the right person to talk about this? I think the consensus was that the parents don't really want to talk to their kids about this. And I think that's right, and I don't think the kids really want to talk to their parents about this either. I certainly would never want to even kind of go around this subject with my mom, and why should a kid with bladder exstrophy have to go through that? So I think it's so important for the camp, right? To meet peers, to meet older peers that are not too old, that are unapproachable, who are old like me with 3 kids. I know, I look like I'm 28, but I'm a little older than that. But it could be intimidating for kids to talk to a 40-year-old male who has like young children themselves, but maybe more approachable for like a young college student or a young professional who recently went through this. And I think it would be really nice to set up maybe a national or international, like a buddy program, to talk about things like that. Hey, like I really like this girl, boy, etc. But I just don't want to go for it because of XYZ, because of the way I look, the way I feel. I saw it on Instagram that this is what a sexual relationship should be like. I saw on Snapchat, I saw on XYZ that this is what it's supposed to be like. This is what the relationships are centered around. But I think as we've gotten older, as I've gotten older, I'm realizing that it really is such a small part of the relationship that is important. At one point, it really is all you think about, but then as you age, it becomes lesser and lesser and lesser. And I think that the kids that are 16, 17, 18 don't have that perspective. And I think it's really important for us to provide that perspective, whether it's coming from us, providers, or the parents, to give them kind of, this will pass, and number one, this will pass, and number two, also you can make the most of it, and you have to and you will, because this is the cards that you were dealt. You have to play it right. Don't fold. And then this is my last slide, but it's about mental health and a frame of mind. I think it's so important to see the world as a glass half full, and not to be hopeless. It's so important to keep hope, that think of this disease process not as a burden, but as an opportunity to do something better, to make the most out of it, lemonade out of lemons, etc., whatever you need to frame it. But it's so important to stay positive. And I think providers have a huge, huge role in that. And I try to incorporate some of the mind frames that I try to instill on our patients with epispadias exstrophy, cloacal exstrophy, on myself, and how I think about my life, and how I want to kind of think about the hardships that I deal with. So, going back to this does not define you, I don't think this should limit whatever activities that you want to do as a family, vacations, trips, relationships that you want to have with your children, your other children. Don't forget about that this is just a small component of your lives, and that we're going to work together. And it's so important to come to groups like this to provide support, to seek support and camaraderie. I don't work in a vacuum. Dr. Bohr in the left upper corner, he taught me everything. He's such a kind and thoughtful person. And Dr. Richard Lee on the upper right is my bigger, older, baldless half. And then we have our team. We have a huge support group. Christina Valer in the back is our social worker. We have 2 nurses, nurse practitioner, physician's assistant, and an inpatient team that supports and is familiar with bladder exstrophy care, epispadias care, cloacal exstrophy care. Thank you so much. Appreciate it.